Greetings, future physicians. Welcome to your focused review of myotonic dystrophy, a key topic for USMLE Steps 1, 2, and 3. This condition is like a persistent house guest. It affects muscles and refuses to leave quietly. Myotonic dystrophy is the most prevalent muscular dystrophy in adults, impacting approximately 1 in 2,100 to 8,000 individuals, so it's one you might encounter in practice. It comes in two types: myotonic dystrophy type 1, the more severe form, and myotonic dystrophy type 2, its milder counterpart. For step 1, genetics are critical. It's inherited in an autosomal dominant pattern, meaning a 50% chance of passing it on if a parent is affected. Myotonic dystrophy type 1 stems from excessive CTG repeats in the DMPK gene on chromosome 19, while type 2 arises from CCTG repeats in the CNBP gene on chromosome 3. These repeat expansions disrupt RNA, affecting muscle function and other systems. Think of it as a molecular glitch with widespread consequences. Notably, myotonic dystrophy type 1 exhibits anticipation, where symptoms worsen across generations due to increasing repeats, a detail step 1 loves to test. Diagnosing myotonic dystrophy requires sharp clinical observation. Picture a patient whose handshake lingers a bit too long. That's myotonia, a hallmark sign. In myotonic dystrophy type 1, muscle weakness targets the face and distal limbs, making tasks like smiling or gripping tricky, while type 2 affects proximal muscles, like the hips and shoulders, complicating mobility. Additional clues include early onset cataracts, vision issues before their time, cardiac conduction defects, which can disrupt heart rhythm, and endocrine problems, such as insulin resistance or hypothyroidism. Myotonic dystrophy type 1 can present at birth in a congenital form, with infants showing severe hypotonia, respiratory challenges, and developmental delays. Type 2, however, spares the newborn phase. Confirmation comes through genetic testing, identifying those CTG or CCTG repeats, paired with electromyography or EMG, which reveals myotonic discharges, electric signals that confirm the diagnosis. For step 2, mastering these clinical features and diagnostic tools is essential to excel. Currently, there's no cure for myotonic dystrophy, but we have effective strategies to manage it. Physical therapy is vital. Maintaining muscle strength and mobility. Consider it a workout plan for affected tissues. For persistent myotonia, medications like mexalatine can help muscles relax more smoothly. Cataracts often require surgical intervention, restoring clarity to patients' vision, while cardiac issues such as arrhythmias may necessitate a pacemaker to maintain a steady beat. Endocrine complications like diabetes or thyroid dysfunction are managed with appropriate therapies. This condition demands a multidisciplinary approach. Cardiologists, endocrinologists, and neurologists must collaborate to address its broad impact. Prognosis varies. Mild myotonic dystrophy, type 2 cases may enjoy a near-normal lifespan, while severe congenital myotonic dystrophy, type 1, can lead to significant challenges, including respiratory failure and reduced life expectancy. Regular monitoring is crucial for long-term care. For step 3, your role is to orchestrate this management plan, ensuring comprehensive patient support.